Assalamu alaikum, everybody. So I've been given this topic, and once I was going through that, I said, you know, uh, what should I do about it? I think these are the topics which, as a basic candidate, even you don't have to be an neonatologist for that. But again, it is an important topic. Jaundice is the main thing which come across to a lot of us again and again. So bear with me if you see some repetitions which you have known or learned before, whether outside this colloquium or during this colloquium. But I'll promise you I'll try to make it interesting in the end, if possible. So my objective would be by the end of this session, you will understand the incidence of hyperbilirubinemia, the metabolism, etiology, how to approach it, and something about the current guidelines, what we are facing right now. This is the physiology. You all know about the blood component, the sinusoid role, the hepatocyte, and then it comes into the small intestine. I don't need to go into detail. Whatever the hemolysis happens here, unconjugated bilirubin goes into the hepatocyte, and then it gets conjugated, comes to the biliary system, and then comes out with the help of bacterial proteases to the feces. 10% goes back, and then eventually it is excreted via feces and urine. So as we all know that the most common condition that require medical attention in newborn happens in around 60% of term and around 80% in preterm babies. There are two types, unconjugated, which we also call indirect, which binds to albumin. It is fat soluble. It can cross the blood-brain barrier, so it is toxic to the brain. And the conjugated, which is conjugates with the glucuronic acid in the liver. It is water soluble, and it is excreted in urine and stool, and it is non-toxic. So I would like to emphasize on 3 time periods. Jaundice within the first 24 hours of life. Jaundice which happens between day 2 and day 14. And then the jaundice which occurs beyond 14 days, what we call a prolonged jaundice. These are some risk factors, what you have seen before as well during the different presentation. The lower the gestation age, again, the gestation age is inversely proportional to the occurrence of jaundice. So as you go more premature, the risk increases. If the jaundice happened in the first 24 hours, if the TCB, transcutaneous, or the serum bilirubin concentration was close to phototherapy threshold, if there is an element of hemolysis, if you have a phototherapy before discharge, if you have a parent or a sibling who needed phototherapy or exchange transfusion, there are some genetic ancestry which is suggestive of inherited red cell disorder, especially glucose 6-phosphate-dehydrogenase deficiency in our area, our part of the world, and the people who are living on the equator. Exclusive breastfeeding is also a risk factor because of the suboptimal intake. Non-hemolytic causes like scalp hematoma or significant bruising, and not to forget Down syndrome and infant of diabetic mother. Now these are the neurotoxicity risk factors. Gestational age less than 38 weeks, albumin less than 3. This is you have seen before as well. Isoimmune hemolytic disease, sepsis, and again significant instability during NICU. These are the neurotoxicity risk factor. Now, jaundice in the first 24 hour, this is not normal. I mean, the commonest cause is hemolysis, either ABO incompatibility or rhesus disease. However, it can be caused by other, either infection which is going from the mother to the baby through the genital tract or the amniotic fluid. So one should consider the possibility of torch as well. When we divide the pathological jaundice, which is again the first 24 hours, we divide them into the prehepatic, which is the unconjugated bilirubin, and we divide them into hemolytic and non-hemolytic causes. And then the conjugated one is the hepatic and the post-hepatic. Jaundice in day 2 and day 14, what we usually call a physiologic jaundice, usually peaking at 7 days, and it could be caused by the combination of factors like fetal hemoglobin. It breaks down at a very high rate, and again the result bilirubin, which cannot be coped by the liver very well. Breastfeeding jaundices again is thought to result from increase in intrahepatic circulation, and jaundice after 14 days, which is also known as prolonged jaundice. Breastfeeding jaundice can continue into the 4th and the 5th week. However, you should not think only of breast milk jaundice. There are several more severe conditions that could cause jaundice. Congenital hypothyroidism, which think of during this time period, and again not to forget the biliary atresia, which is rare, but again it is a very important causal relationship with the conjugated jaundice. Now, these are the initial investigation. As with everything, the first of all, a thorough history and examination that would lead you to the diagnosis. We do the serum bilirubin, the CBC, blood film and retics to see the rate of hemolysis. We also do the blood group and then the LFT, looking at the obstruction pattern or the intrinsic liver pattern, thyroid function test, blood culture, Coombs test, and one should not forget about the urine dipstick to rule out UTI. This is a schematic diagram. If you're looking at the indirect hyperbilirubinemia, it could be either prehepatic, physiologic, or pathologic. If it is pathologic, again the physiologic onset within the first week, and the baby is clinically well. And when you're looking at the pathology one, it can be either due to increased bilirubin production, it could be either due to non-hemolytic, secondary to cephalohematoma or polycythemia, or the hemolytic, which can cause increased production of bilirubin. Again, we divide hemolytic causes into the intrinsic and the extrinsic component. Extrinsic one would be the immune-mediated, isoimmunization, sepsis, and the intrinsic one, which is related to the baby own red cell, like spherocytosis, elliptocytosis, G6PD, etc., etc. The decreased bilirubin clearance could be due to the breast milk jaundice, Gilbert syndrome, and Crigler-Najjar, and there would be an element, can be an element which could cause increased jaundice, like GI obstruction, breastfeeding jaundice, and this is as a result of increased enterohepatic circulation. When we are dealing with the prolonged jaundice, the first question which comes in our mind is the feces depigmented? If it is yes, then you do the basal lab chemistry, you do the ultrasonography, and you try and exclude all these causes of depigmented stool like biliary atresia, Alagille syndrome, neonatal sclerosing cholangitis, alpha-1 antitrypsin deficiency, cystic fibrosis, choledochal cyst, and biliary sludge. And following that, you do the liver biopsy, RCP, and so on and so forth if needed be. and intraoperative cholangiography. And if the pieces are not depigmented, then again you do the ultrasonography and you try and exclude infection, hypothyroidism, you do the thyroxine level, ferritin, cortisol, and try and do alpha-1 antitrypsin and the PFIC, some metabolic disorder. And further differential diagnosis again depend on the results, what you are coming across. So it's an exhaustive list of doing a prolonged jaundice. We tend to involve our gastroenterologist and the pediatric surgeons when we are dealing with the prolonged jaundice. You have all seen these threshold or these nomogram, these AAP guidelines. They have revised them in 2022, and they have come up with all these thresholds. The one with the no neurotoxicity risk factors, and then one with the one or more neurotoxicity risk factors. And the other thing which I would like to mention, that how do you approach and identify newborn whose mother has anti-erythrocyte antibodies during the pregnancy. And they have described the mother antibody screen is done, then the maternal antibody screen, if it is positive, then you should do the infant Coombs test and blood type. And if it is not done, then still you do the infant DAT test, or whether find out the infant is DAT positive. And if the infant is DAT positive, so then you go on and do the threshold and see the child is at high risk for developing jaundice, and measure that TCB or the TSB immediately, then every 4 hours 2 times, and then every 2 hours 3 times. So these are the guidelines which again, this is the exchange transfusion threshold with no hyperbilirubinemia neurotoxicity risk factor, and this one is the one with one or more hyperbilirubinemia neurotoxicity risk factor. This is the approach of escalation of care. I mean, if the baby has an escalation threshold which is defined as 2 milligram per deciliter below exchange transfusion level, then you could escalate the care of the baby and try an intensive phototherapy on this child. Now we just go on some evidence what we have, and this is based on the grade, which is the assessment, diagnostic and evaluation. And level A would be the comprises of the well randomized controlled trial, and level D would be the observational studies. Level X would be the one which is an exceptional situation in which validating studies cannot be performed. So we looked at it, that what is different things which come in our mind when we were dealing with the babies with jaundice. There are certain questions. The first question which comes is, when is the DAT needs to be done? We looked at this question, and they said that if maternal antibody screen is positive or unknown, the infant should have a DAT test done, and infant blood type should be determined. And this has a aggregate quality evidence of grade B, so this is a strong recommendation. And also not to forget that if the mother has received RH immunoglobulin during pregnancy, so that can also be falsely positive. When we look at the benefit and harm assessment for this, the benefit of knowing the risk of severe hemolysis through early DAT testing likely exceeds the harm of a potential extra blood draw. So these are the recommendation, that if the mother screen is not known or positive, then the infant should have a DAT and a blood group determined. So the next question is the oral supplementation. Do we need oral supplementation of water and dextrose? So the guideline says the oral supplementation of water and dextrose should not be provided to prevent hyperbilirubinemia or decrease the bilirubin concentration. And again, this is a grade B strong recommendation, strong evidence, and a study if the infant were fed supplemental water. There's another supplementation with water and dextrose was associated with higher bilirubin concentration on day 6 after birth. So on the benefit of and harm assessment, there is no evidence of benefit of routinely providing water and dextrose supplementation, and there is a possible harm including interference with breastfeeding, taking the baby away from the mother, hyponatremia, and possible water intoxication. So the next question is TCB is enough to detect hyperbilirubinemia? Again, I think this morning we had this Draeger JM transcutaneous bilirubinometer. The guideline recommend that the total serum bilirubin should be measured if the transcutaneous bilirubin exceeds or within 3 milligram of the phototherapy threshold level, or transcutaneous bilirubin is showing more than 15 milligram per deciliter of bilirubin, then one should do the total serum bilirubin on this baby as well. Again, the TCB is a good screening test, but it is not accurate. Once that your treatment threshold reaches at those levels, then one should do the total serum bilirubin. When they did the benefit and harm assessment, again the benefit of having a more accurate measure to guide treatment decision outweighs the discomfort associated with measuring the TSB. So recommendation is once you reaches at those level, do the serum bilirubin. So when to investigate a prolonged jaundice? Again, the breastfed infant who are still jaundice at 3 to 4 weeks of age, and the formula fed infant who are still jaundice at 2 weeks of age. The total and direct reacting or conjugated bilirubin concentration should be measured to identify the pathological cholestasis, and these are the recommendation is grade X, like it cannot be, we have to do it. The benefit and harm assessment would be the benefit of early identification and treatment of pathologic causes of cholestasis outweighs the harm. Again, extra testing, extra cost, but there is far more beneficial in knowing the possible pathologic cholestasis. Do we need additional blood testing for infants who receive phototherapy, especially the one who are DAT positive? Again, the rate of hemolysis is higher, so one should keep an eye on hemoglobin concentration, hematocrit by doing the CBC. And it will also provide you the baseline just in case if later on when you're following the baby in the clinic for the presence of anemia as well. G6PD activity should be measured, and the benefit and harm assessment reveals that the estimated overall benefit of providing potentially useful information is expected to outweigh the potential harm. So recommendation is, especially in DAT positive babies, that you need to have a baseline for the babies who receive phototherapy. When to discontinue phototherapy? Um, Again, discontinuing phototherapy is an option when the total serum bilirubin has decreased by at least 2 milligram below the hour specific threshold at the initiation of phototherapy. So when you started the phototherapy and you have given a phototherapy for a number of hours and you're repeating it, I mean, if it is 2 milligram below uh, your hour specific, so you should think of the levels when you have started phototherapy, not 4 hours later when you have completed the phototherapy. Again, the longer phototherapy is an option if there are risk factors. Again, the benefit versus harm assessment would be these levels are suggested, the 2 milligram below the hour specific threshold. These are suggested to discontinue phototherapy, which reflects an attempt to minimize the duration of phototherapy and again the complication related to the phototherapy. And we can always restart if there is a need to initiate it again. Again, just to minimize the phototherapy side effects. Do we need IV fluids during intensive phototherapy? So recommendations are infant requiring escalation of care only should receive intravenous hydration. And this is done just to buy some time, before you're taking a decision for the exchange transfusion. Again, TCB should be measured at least every 2 hours from the start of escalation of care until the period either it escalates and you go on and do the exchange transfusion, or the TCB has gone down 2 milligram below the hour specific threshold, then you should continue the intensive phototherapy and IV fluid. So benefit versus harm assessment, the possible benefit of preventing an exchange transfusion outweigh the potential harm related to IV fluids. So it's just to buy some time, and maybe with an intensive phototherapy and IV fluids, if the levels gone down, then that could prevent doing an exchange transfusion on this baby. Role of immunoglobulin, again, controversial evidence for the use of IVIG. They recommend to use that for that positive one whenever there is an antigen antibody complex, they're saying. But again, the IVIG is, there is a risk of necrotizing enterocolitis related to IVIG. But on the other hand, there is a risk of necrotizing enterocolitis related to exchange transfusion. So again, the benefit of IVIG are not clear, and there is a small risk of harm. So treatment with IVIG may be more strongly considered if there is a poor response to phototherapy and if there is a difficulty obtaining, the exchange transfusion. Okay, so when should we do the exchange transfusion? There are times when these babies comes in with already in bilirubin encephalopathy, and some of us would say, that we have missed the boat. The child is already showing sign of early connectors. There are some case reports and case series which suggest an immediate exchange transfusion. It may prevent connectors in some infants by the reduction of the time the brain is exposed to the high serum bilirubin. Again, the evidence is grade C. The risk of exchange transfusion includes NAC, apnea, hypocalcemia, electrolyte abnormalities, and thrombocytopenia. But when we weigh them at the benefit-harm assessment, the benefit of avoiding connectors or reducing its severity among newborn already showing sign of bilirubin encephalopathy probably make us do the exchange transfusion, and it exceeds the risk related to exchange transfusion. Thank you very much.